Hello and good evening, everybody. I hope you can all hear us and see us. And so welcome to the session on the genetics of breast cancer. And so I'm one of the speakers. My name is Aletta Pohl. I'm a genetic counselor here at Women's College Hospital and the Hereditary Breast Cancer Clinic. And I've been here for about 20 years. And so I'm also the moderator for this session today. And we have two other great speakers, and I'm going to let them introduce themselves. First, we have Dr. Tulin Sil. And Tulin, do you want to give a little rundown on yourself?
Sure, thanks so much, Aletta, and thanks for having me tonight. As Aletta said, my name is Tulin Sil. I am a breast surgeon. I work at Princess Margaret Cancer Center as well as Women's College, and I have been in this role for just over 10 years, and so work very closely with two groups of plastic surgeons, both at UHN and at Women's College, in doing not only cancer surgery and reconstruction related to cancer operations, but also risk reduction mastectomy for patients with an elevated lifetime risk. So happy to be here tonight and answer any questions. Thanks.
And now over to Kelly, Dr. Kelly Metcalf.
Hi, everybody, and welcome tonight. My name is Kelly Metcalf, and I am a senior scientist at Women's College Hospital. And my research is focused on the prevention of hereditary breast cancer. So I do a lot of work looking at prophylactic mastectomy, as well as the treatment of hereditary breast cancer. So for women who have a mutation in a cancer predisposition gene like BRCA1 and BRCA2, how should we best treat those breast cancers, because they are different than the average breast cancer, to ensure that we can increase the chance of a woman surviving her breast cancer. So a lot of my research is related to reconstruction and breast surgery, but also breast reconstruction. So I'm happy to answer any of your questions here tonight as well.
That's great. And so we have some general questions that I think might be helpful to anyone who's listening. And also we have a few patient questions already that were provided to us beforehand. If you have any questions or anything that occurs to you while this session is going on, we have about 45 minutes or so. Please just put them down in the chat, and I will do my best to include them in the session, because we want to make sure as best as we can that everyone's questions get answered. So one of the first ones I think that people often think of in when it comes to the genetics of breast cancer is, how likely is it that my breast cancer is hereditary, or the one in my mother or relative? And also possibly who should get genetic testing. So I think that's a good place to start here. Now, breast cancer is a very common cancer, and actually the majority of breast cancers that happen are not particularly hereditary. It's just 1 in 8 women get breast cancer in their lifetime. And if you think about it, that's a lot of women out there, unfortunately, developing breast cancer. But most of the time it tends to be in women who are a little bit older, usually women after the menopause, in their 50s, 60s, and 70s. So just because someone has maybe 1 or 2 people in the family with breast cancer, it doesn't have to mean it's hereditary or if you got it yourself. However, there are a small portion of breast cancers, about 10%, that can happen because a woman was born with a genetic change that made her more prone to get breast cancer. And that tendency to get the breast cancer can be passed down through the family. And that's what we call hereditary breast cancer. And usually the signs in the family are things like when someone maybe gets breast cancer at a younger age, more in the 20s, 30s, 40s, that sort of thing. Or if you see multiple people in the family getting breast cancer, you know, a mom, a daughter, an auntie, grandmother, that sort of thing. And then we also look for certain combinations of cancers, which can sometimes indicate that there may be a hereditary component. So if we see breast cancer and ovarian cancer in the same family, it can make us a little bit more suspicious, but you don't have to have it in the family for it to be hereditary. And then another thing is also certain types of breast cancer are a little more likely to be. For an example, triple negative breast cancers are a little more likely to be hereditary than ones that aren't, but definitely they don't have to be. So just because you have a triple negative, it doesn't mean it has to be. So those are the sort of things we would look for in a family. And usually people can go to a genetics clinic, and we'll maybe touch on this a bit later, some of the options of how to get genetic testing. And the testing has also changed over time. But for the longest time, we were just looking for two main hereditary breast cancer genes, the BRCA1 gene and the BRCA2 gene. But in more recent years, we've started testing women or families with multiple cases of breast cancer for more hereditary cancer genes. There are extra ones like POLB2, CHEK2, PTEN, STK11. So there's a series of other genes that can be looked at. And so this whole field has really expanded in the last few years, and we're identifying more people with now a hereditary predisposition to get cancer. Some of them have had breast cancer already, but also some of them haven't. And so maybe some of the both of those kind of people are actually listening today. And so they can consider things like, in some cases, to do a risk-reducing mastectomy to lower the chances of developing breast cancer. But the option of doing that depends on the level of risk that somebody is at, and also personal preference and family history and age and situation. So there's a lot of factors that play into it. But maybe I'll just start off by just touching in with how well does this actually, that risk-reducing mastectomy, work in terms of preventing new breast cancers from happening? I know this was touched on one of the first sessions, but in case you missed that, I'll maybe start by sending that first over to Kelly, who has done specific research in that area.
Yes, thanks, Aletta. And we definitely have research, published research and research out of our group at Women's College that suggests that it significantly reduces your risk of developing breast cancer. So some of the earlier research that looked at preventive, or what we call now is risk reducing mastectomy, because it doesn't bring your risk down to zero. But when we're thinking about a woman that's having this type of surgery, we're talking about a woman who has a 60 or 70% lifetime risk of developing breast cancer, compared to the average woman that has an 11 or 12% risk of developing breast cancer. So we have to keep those numbers in perspective. And when we think about this risk-reducing mastectomy for a woman who has that very high lifetime risk of developing breast cancer, 60, 70%, we're bringing her risk down to below what we would see in the general population. There still is a small risk that a breast cancer could develop. Again, that risk is very low, especially with the newer types of surgery. And maybe Dr. Sill can talk a little bit about that, but the newer types of surgery where we know, the surgeons know that they're dealing with someone that's at very high risk. So they're very careful to remove as much breast tissue as possible. What we don't have yet is the data. We have some preliminary data at Women's College that I'm happy to share with you tonight about the impact on survival. So that's the ultimate question. If I have this type of risk-reducing surgery, am I going to increase my chance of survival? And we do have very good evidence that yes, this significantly reduces a woman's risk of dying of breast cancer if she has a BRCA1 or 2 mutation. So this research is taking a long time to do. It takes a lot of follow-up of a lot of women with BRCA1 and 2. And I'm talking specifically about BRCA2 because I also see a question in the chat about POLB2 that I can also talk about a little later if we have time. But yes, we are working on that to the person who's asked about POLB2. It's a newer gene that we've been testing. But again, really important to look at how to best treat those POLB2 breast cancers. And we do have a study going on at Women's College. So if you're interested, please contact me. But anyways, I don't know, maybe Dr. Still wants to add something to that in terms of the surgery.
Yeah, thanks, Kelly. It's a common question, what is the outcome if I do have this big surgery in terms of reducing risk? And I do like the term risk reducing mastectomy because it really emphasizes that we can never eliminate the risk. Unfortunately, nothing brings it to zero, but it is quite significant in terms of that 90-95% reduction. The other thing is more in the past decade, I would say we've really embraced nipple sparing mastectomy as a very good option for many women, and maybe we'll touch on that later. But in the past, the nipple and areola complex was routinely removed when these types of mastectomies were done, and more, if a patient's a good candidate for nipple sparing approach, that can be done. Now, when you do keep the nipple, we do know we are leaving some more cells behind that, theoretically could increase risk because the milk ducts terminate right in the nipple. And while we go very, very close and go as close as possible under that nipple, we still need to leave enough tissue to give it some blood supply. So that's one of the questions that's arisen, and there's actually some good data that was published a few years ago, which looked at outcomes of patients with a BRCA1 and BRCA2 mutation, and they had looked at almost 550 women over about a period of about 5 years and found none of them developed a breast cancer. So that was quite reassuring in that time interval. We don't see, breast cancer develop. And if you modeled, how many women would have developed breast cancer in that situation over that time period, it was estimated to be about 22 women. So, clearly it was doing its job in terms of risk reduction. We don't have very long-term data. And as Kelly pointed out, that's the limitation of breast cancer studies is, we do want to look ahead 10 to 20 years to really have more definitive information.
Great, that's very helpful. And so there's been a few questions, and I just want to try to answer some of them as we're going through so they don't pile up too much. There's an individual who has sort of an unusual scenario that there was a known mutation on her dad's side of the family, a BRCA1 mutation. She developed breast cancer and was found to have a BRCA2 mutation. Now, her father had pancreatic cancer and passed away from that. And pancreatic cancer is, well, it can be associated with either BRCA1 or BRCA2, but it is more associated with the BRCA2 gene. And so she's wondering if both could have come from her father's side or if one came from one side and one from the other. And the question is, it could be either. They could have both come from your father's side of the family. But to answer that question, you should probably get your mother tested just to make sure that whether it could have come from hers and just not been shown up on her side. So I just sort of wanted to answer that question. And there's two sort of similar questions that are around when you have a strong family history, but you haven't found a genetic predisposition, do you really consider risk reducing mastectomy in that situation? And so I'll start by getting Dr. Still's opinion on that, and then I'll come back to it. So Tulin, what would you say?
So, now we consider a lifetime risk of over 25% at elevated risk. And, patients with a lifetime risk of over 25% do qualify for Ontario high-risk breast screening program. So they would undergo yearly screening with mammogram, clinical breast exam, and MRI. And so I have had a fair number of patients come in that scenario where they don't have a documented genetic mutation that elevates that risk, significantly high. But there's enough there that there's some family history and in combination with maybe personal history. And I think it's a very individual decision that we have with discussion with the patient, and just looking at what things are important to them in terms of moving forward. We do know that we have excellent capacity to do breast screening and catch things at a very, very early stage with such intensive screening. But for some women, they do want to pursue a surgical approach to reducing risk in terms of maximal risk reduction. So I think it's really understanding what your current risk level is, and then understanding that you're going to decrease that risk, but at the in terms of the action, it's undergoing a fairly big surgery with then issues about ongoing surgical follow-up and different aspects of that. So we have a very one-on-one discussion with patients in that category for sure.
Yeah, and the genetics clinic can help with that, because usually if you were seen in presumably you were seen in a genetics clinic, they do try to use some models that will try to estimate your chance of getting breast cancer in your lifetime. So you'll have a bit of an idea of that level and where you fit, and whether you're eligible for probably for the high-risk breast screening in that case. And so then you're weighing up those options, but you can, if you feel more strongly about it, definitely get the opinion of the surgeon and see how you feel about it on the whole.
Aletta, can I just touch on just one question, I guess, from your perspective? I think one of the questions was about previously testing negative from genetics. And now, in what time frame would you recommend that a patient get retested? Because as you were saying, there's much more that we know about in terms of new genes.
And that is definitely something to consider in families. Usually, if at all possible, when it comes to doing genetic testing in families, it's a lot more informative to test a person with cancer than an unaffected individual. I just want to say that sort of to start with. But also, as I mentioned, the testing has changed. And so if you were tested, and this could vary a little bit between the provinces, but in general, before 2017, they were mainly doing BRCA1 and BRCA2 testing and not looking for a lot of these other moderate risk breast cancer genes at that time. And like sometimes they would on a one-off basis or on a research basis, but not consistently. And in more recent years, they've now started testing people for a series of hereditary cancer genes. So if you were negative previously, say 10 years ago, it may be worth contacting your genetics clinic, and you may well be eligible for updated genetic testing, and you can be tested for more hereditary cancer genes just to make sure that there isn't a CHEK2 mutation or a POLB2 mutation or something in the family. One of the other questions was it was a bit around the same issue, but it was also indicating that they had a family that there were a number of people who carried mutations, but even some people who didn't have mutations still got breast cancer. And that's something that's very important to realize, is genetic testing is not a glass ball that's going to tell you whether you're going to get it or not. It's telling you something about the probability of getting it. And so if you are born with a mutation in one of these hereditary cancer genes, your risk can be increased. And depending on the gene, it can be increased to different amounts. But even if you don't have any problems with any of these genes, you can still get breast cancer, because 1 in 8 women do, and they don't have to have anything going on. So just because you've had somebody have that, it doesn't mean that you're at intrinsically higher risk. So that's not necessarily a concern that way. And sorry, I'm just trying to scroll down to see more questions because there's lots of them, which is great. Okay, and so there's a question about ATM mutations and how they can be, whether a risk-reducing mastectomy can be effective. And so in terms of the actual surgery, I think no matter what gene mutation you may or may not have, the effectiveness is what Dr. Sill said it is, and Dr. Metcalf, like it's very effective, but it's not 100%, but it is it's going to do the most to reduce your risk of getting cancer. I think the question with some of these more moderate risk genes like ATM is it worth, how worth it is it doing it? It's not always clearly strongly recommended for some of these more moderate risk genes because of the level of the breast cancer risk. So with an ATM mutation, most of them are having a risk sort of in the range of 30 to 40% chance that you could get breast cancer. And so for some people that seems like a huge number. Other people it's like, it's not that bad. I can go for breast screening. I can get breast MRIs. So it's not necessarily that everybody has to do that. Other gene mutations the risk might be more like 70%. So it's a much more significant level of risk at that point. And our recommendations.
I just add something on to that, Aletta, too. And the thing about some of these newer genes and the breast cancers that are associated with these genetic mutations is we don't know a lot about these breast cancers. We don't know if they're going to be very aggressive breast cancers that we want to avoid at all costs. So that's something that we're really trying to evaluate right now. We have some early data that POLB2 breast cancers may be quite aggressive. And so we're looking at that, and we're looking at if a woman with a POLB2 mutation, and we don't know for sure, has a worse prognosis than someone with sporadic breast cancer or a BRCA1 or 2 breast cancer, we may want to consider, or a woman may want to consider risk reducing mastectomy, even though her lifetime risk of getting that breast cancer is lower than a BRCA1 or 2 mutation carrier. If the cancer is worse, a woman may elect to reduce that. So that's a lot of the research that we're doing right now, is trying to understand these breast cancers and what the prognosis looks like for these breast cancers, because that will really help a woman in making a decision about whether or not a risk reducing mastectomy is right for her. So being able to give all of these answers will help with that decision-making process. So again, if you have breast cancer and an ATM mutation like the POLB2, please be in touch, because we are doing studies on those genes right now.
And so somebody was also asking about BARD1, which is one of these newer genes where we haven't got as much data yet, actually, even on the exact level of risk that can go with it. We do feel it's elevated, but the exact level isn't known. But there can be a bit of a concern that it may be more prone to have a certain kind of breast cancer that is a bit more aggressive. Again, as what Kelly was saying, they can be a little bit more prone, they think, to get triple negative breast cancers, which are a bit more aggressive. So I think that information is still evolving, and we're in kind of an odd situation that we're testing people, but we're just still collecting information and trying to fully understand what everything means, and we're not quite there yet. Dr. Sill, I just wanted to ask, like, when it comes to a number of these different gene mutations, do you feel, how do you feel about suggesting risk reducing mastectomy for some of these moderate risk genes?
Yeah, I mean, again, I think that's where, the discussion with genetics really comes into play, and really understanding, what that future lifetime risk has, is for the patient. And for some women, even with a BRCA1 and 2 mutation, they're very happy to continue with ongoing screening, imaging, surveillance approach. And I, of course, see a bit of a different population in patients who are really strongly considering surgery or have decided to have surgery, So, I think that there obviously are different factors to consider for every woman in terms of what they choose. In the end, we know the mastectomy is, as we talked about, extremely effective, but you have to consider all of the aspects of undergoing the mastectomy, if you have reconstruction, all the things that go along with the reconstructive aspect, and then what that future is going to look like for you compared to on the ongoing screening. There can be a lot of anxiety associated with screening too, which is definitely one of the other things that sometimes really drives women to really strongly consider surgery because of the concerns around potentially finding something, with each of these screens. So there's no right or wrong. I think it's really just, very, very much a personal decision.
Great. And so another individual was asking about the level of risk when somebody has a known gene mutation versus someone who just has a family history. I would say, generally speaking, the risk with just a family history, it is increased above the population level, but not usually to the same extent as with a known mutation. But that is, we're in a family where you definitely have tested maybe a couple of the affected people to make sure that there isn't a gene mutation there. That's, sometimes you can just test the wrong person who happened to get a sporadic breast cancer in a hereditary breast cancer family. But if you're kind of fairly confident it's not due to any genes we could test for, then the hereditary risk is maybe more in the range of double the population risk. Well, a lot of the gene mutations are sort of in the range of 4 to 10 times the population as a gross generalization. Someone else has a little bit more specific question that I think they have a triple negative breast cancer and a BRCA2 mutation, and they're wondering about nipple sparing mastectomy. And we touched on that a little bit earlier, but again, I'll maybe leave that to for Dr. Sill to comment on. Or
yeah, I mean, so with that discussion about what approach and what type of mastectomy to have, it really depends on sort of two factors, and one would be, is it safe from an oncologic perspective, and is it the best option for you from a reconstruction perspective? So, from my cancer perspective, we used to want to have, a distance of about 2 centimeters away from the nipple in order to say it was sort of a safer margin from the disease. But now, unless there's sort of direct nipple involvement, or we are really, really concerned about the potential for a positive nipple margin, a lot of patients are really candidates for a nipple sparing approach from a cancer treatment perspective. So it's not as high of a concern for us in terms of risk of local recurrence, even in the setting of sort of more aggressive disease, potentially from a biologic perspective. When we talk about the reconstructive aspects, that really depends on the breast size and shape and position of the nipple to say if it's recommended to be doing a nipple sparing approach versus a skin sparing approach, where you have a little bit more potential to change the shape and size, or to change the nipple position. So those are kind of the factors that we think about when we're looking at all of those options for mastectomy.
okay, and a quick question, which I think is a sort of a clear answer, but I believe they were asking, if you start off with having implants, can you later switch to using your own tissue when you're older? And I'm pretty certain the answer is yes to that. I presume you agree? Yep.
I mean, again, using your own tissue really depends on if you've had and a DIEP flap, with your abdominal tissue being the most common kind of autologous approach. Previous abdominal surgeries and things, that could impact on the potential to use your own tissue. The other thing is it is a significant recovery period for a DIEP flap, because you have to consider that it's not only surgery with terms of the breast reconstruction portion, but the abdominal part of the surgery. So it's definitely a bit of a harder recovery than the implant-based reconstruction. So as you get older, that factors into your surgical decisions.
Right. And someone was also asking, they're a mutation carrier in BRCA, and they were asking about the recovery time, and they're a little nervous of the drains. But I think it would make a difference whether you're doing this in the prophylactic setting where you don't need to worry about taking out nodes under the arm versus in the cancer setting where it may be necessary to take nodes out, which complicates the issue and recovery.
Certainly, yeah. I mean, it definitely is a little bit more difficult to recover with the axillary portion of the surgery. And it also depends on factors like, are you going to have a one-stage implant-based reconstruction or two-stage tissue expander and then implant, because that's two separate surgeries, or are you going to do an autologous, flat-based reconstruction? So all of those different approaches have a bit of a different recovery time. I mean, in general, for most women who are doing it for risk reduction, because they tend to be a bit younger, they're coming into it quite well and healthy, and can recover from surgery in several weeks, sort of getting closer to their baseline. You do have to anticipate that you're going to have some limitations in terms of lifting and also some post-surgical fatigue. So that like any surgery is always something to manage. And we can often do these surgeries as a day surgery or even overnight when we're talking about implant-based reconstruction. So that's definitely one advantage too, to recover more so at home.
Right. There is a carrier who is asking about whether to do screening more frequently, to have the mammogram and MRI screening, whether it's better to do them together once a year or space them out. I think that might depend on the province you're in and how it's managed. I know in Ontario, they prefer to do them together because they feel that they can more accurately see whether the breast cancers are there if they can compare them to each other, the images done at the same time. They used to do them spaced out, and then they felt like that was the better way to go. But it could be different in different provinces. So I don't know that it's always an option to pick. I know in the high risk program in Ontario, they prefer to do them together because they feel that's more beneficial and they don't feel like they have to do them more often. They don't get that many cancers that come up, what they call interval cancers that come up between the screens, as long as you're going reliably every year for them, and if you're at high risk. In terms of HER2, there was a question about that, about HER2 new. That's a characteristic of the breast cancer. In terms of it's in general, they were asking about how that could be associated with genetic risk. HER2 positive breast cancers are a little less, they're not as typically hereditary as far as we know at this point, though there is one of the genes that we can see it a little bit more in, but it's not one of the more common ones that we see. But the main issue is just in how to manage and treat that cancer. I think that's the main significance of a HER2 positive, is really about treating the cancer itself. And
can I just ask Kelly
yeah,
a question about that? Are you seeing HER2 more associated with any of the other gene mutations at all? Just needed.
Sorry, I'm on mute there. No, we haven't been, although we haven't really studied many of these cancers really well. So we're 20 years ago where we were with BRCA1 and 2 and trying to understand these breast cancers. We're now there with all of these newer genes because we've really just started testing women for these other genes within the last 5 or 10 years. So, but we are actively working on understanding these other cancers right now.
and this might also be a little good segue into also about how to get testing for inherited mutations, because there's a few different options that are available in that. One of the historically how this was typically done is that you get referred by your family doctor to a local genetics clinic. And if you meet certain criteria, you may be offered genetic testing. And that's still one of the main routes. But there are other options. The one thing that they're doing in certain places across the country is surgeons like Dr. Sill might be ordering it directly on someone who's just diagnosed. And are you doing that more now, I think, at Princess Margaret?
We are, if they fulfill some of the criteria that where we know that, they would benefit from genetic testing. So if they're diagnosed very young, or if it's a male breast cancer. So we are sort of instigating the genetics testing right off the bat when we see them. And I think, one of the advantages of getting the genetic testing starting really early is that we often plan for surgery in a very short time frame, and these types of changes in decision making can really be impacted, of course, by the genetics results. So I think learning more about the lifetime risk and can impact on a woman's choice about what type of surgery she's going to have. And we're making those surgical decisions generally in that sort of shorter time frame. So I think it's a good idea to get it quickly if we can.
And Kelly, that's why you started up the rapid genetic testing study, right?
Yeah, so we're doing a study. It's a second part of a study. We're doing it at Women's College. So we have criteria for testing for women at the time of breast cancer diagnosis. So if a woman meets criteria, which is more relaxed than general genetic testing criteria across the country, either her surgeon can refer her in or a woman can self-refer. And we do rapid genetic testing. We send a saliva kit to the woman's house. She spits in it, we send it to the lab, and we get the results back in about 6 or 7 days. So it's very fast. It's just, we're trying to increase access to genetic testing. I think if women, I'm a real believer that if a woman wants to know this information at the time of breast cancer diagnosis, she should be able to have that information to help her make a surgical decision. So yeah, so that's open to anyone across Canada at the time of diagnosis, so pre-surgery.
Yeah, and it is I think a fabulous study, and I'm the main genetic counselor working on it. And so and if people want to self-refer, they can go to the Women's College Hospital page and put in the rapid genetic testing to study, and you'll find information there, and you can enroll online. The other thing is another project that was started here with our team at Women's College, is a way for people who maybe don't meet criteria, but would just like testing, but would like to pay for it themselves. We've tried to find an affordable way for them to do it. And it's called the Screen Project. And so people, any adult in Canada, can just sign up online, have a kit sent to them. They do testing. They start off with BRCA 1 and 2, but if you want, you can be tested for an additional 43 genes, so a total of 45, and all for the same price, which is $250 US. And that includes shipping. That doesn't come to the hospital at all. It all goes to the testing company. And if anything is found on the test, there's a study genetic counselor who speaks to you, and you're looked after that way. So you're not just left with the information. So it's just another I think there's a lot of different options now to get testing, because this information can be so important for people and to know about the risks. So I know we're coming to the end, and I want to see if I can get through just a couple more questions. Someone was wondering about the risk of contralateral breast cancer for CHEK2. It really depends on the exact mutation you have. There is one lower risk mutation. The other ones are still it's still moderate risk, and this is why a lot of these studies are now being done on these other genes to find out exactly what is the risk for someone who has a CHEK2 mutation who has breast cancer to get a second one. And they don't have the exact numbers yet. They feel it's elevated, but not as high as for BRCA 1 and 2, but we don't have an exact number. And then questions about weighing up risk-reducing surgery versus screening. That is a personal decision, because there's so many I think choices and people's situations are so different. And there's no guarantees with either scenario, and you're the individual who has to live with the consequences. So you have to decide what's right for you and what risks are acceptable.
Aletta, can I just speak to that one? There's one comment about doing the prophylactic surgery and then stopping screening. And you're right in that generally we do recommend that you don't need to have ongoing imaging tests on a yearly basis. There's really no benefit of a mammogram after you've had the mastectomies, nor really MRI either, but clinical breast exam is important. Watching for any changes in the skin, in the nipple, any new nodules, anything in the underarm area within a large lymph node. I mean, those are all signs and symptoms that should be checked, absolutely. But remember, after you've had the mastectomy, your new risk is lower than an average risk woman's risk because we've reduced the risk so much. So essentially we are able to really screen you well just with the clinical exam and not need to have you undergo a mammogram and MRI every year.
And some of the questions that were proposed earlier, one of them asks if the mastectomy will reduce the risk of the breast cancer recurring. And I'll let Tulin answer that one as well.
I mean, certainly it does in terms of local recurrence, but with a patient with a breast cancer diagnosis, we worry about a distant recurrence as well. And so that's where that total treatment plan comes into place, where we think about the medical therapy for a patient, whether that be chemo or endocrine therapy or both, and then radiation if that's needed as well. So all of those treatments really work optimally to reduce risk, not only for local recurrence, but distant recurrence.
Right, so we're coming to the end of the time. Thank you so much, Dr. Sill and Dr. Metcalf. It was super helpful, I hope, for everybody. And if you have questions, you can always reach out, and there's information about also the topics, some of the topics we talked about on the Women's College website. So that's it, and have a good evening. And thanks for listening.
Thanks.